All right, so we have quite a few attendees, so I think we can go ahead and get started. Um, so welcome everyone to the Robert Allen Memorial Hematology Symposia. Our presenter today is Jonathan Gutman. He's an associate professor here at University of Colorado. He's one of our bone marrow transplant experts. John did his fellowship training at University of Washington, and he joined our division back in 2009. And since then, he's not only taken excellent care of our bone marrow transplant patients, but he's really been at the forefront of transplant research. He's been the principal investigator of many important clinical trials, and he has over 60 peer-reviewed publications in this field. And today, John is going to talk to us about venetoclax and transplant in AML, and I am looking forward to hearing this talk. So take it over, John.
All right, thank you, Maria. This may have come up last year at this talk, but I'm taking increasing flack over my youthful picture and told that I need to update to something more appropriate to my current level of seniority. So stay tuned next year. An old gray beaten up person. This I think is just sort of a informational slide. Hopefully I am not skilled with the Zoom, but at least it's working. But definitely hope to be able to answer questions as they may come up, and hopefully Maria can help us mediate that for sure. And feel free to interrupt, but I think we'll have a little bit of time at the end for Q&A also. Just again, some housekeeping details. All right, so venetoclax and transplant in AML. I think this may have been my idea, or maybe Dan sort of asked for me to discuss this topic, but being the clever person that I am, I came up with the idea of calling it "Oh, the Places You'll Go," and you know, I spent a lot of time getting this little guy here to stick on the slide appropriately. You'll see his little Venn hat there. There's actually a little more to the story, which I'll tell you in just one second. And you know, much of the story, the clinical story of venetoclax, I think Dan has been such a prominent figure and gave him some credit for the novel. But as it turns out, in fact, Dan's not on the talk today because he's over in Germany giving a talk to all of Europe, not just a regional talk, a little regional talk here. And they actually provided him a title for the talk, which was Treatment of AML, the Colorado Way. And so we really are, along with venetoclax, is going lots of interesting places. And I have no disclosures, but we'll kind of dive into what I want to talk about today in just one second. But I did want to make the point that little figure on our "Oh, the Places You'll Go" slide there was not just made up for me for the sake of this talk, but for those of you who follow our work very closely and you know, follow our serial Blood Advances papers related to the issue. Blood Advances asks you for a visual abstract, and while most take that as an opportunity to put in some chart or data, we take it as an opportunity to get a little bit creative. And we've been following the story of venetoclax since back in 2019 with his friend azacitidine, some of his fights against 7+3, which we'll be talking about today. So let's get into the real substance of things with all that fun aside. I think most everybody in this audience is well aware of the advancing role that venetoclax and azacitidine has made in AML. Just data here from the Viallier trial, the randomized trial of azacitidine plus venetoclax versus azacitidine in AML patients. Importantly, this trial was older patients, 75 plus, or patients deemed not candidates for induction due to comorbidities. I think most know that we in Colorado might take a slightly different interpretation of what an induction candidate looks like than other centers. But this trial was the basis for the approval of ven-aza as first-line therapy in older or comorbid patients. And I think, fair to say that Ven/Aza has become the standard of care in that population. But we in Colorado have been big advocates for advancing the use of venetoclax and extending its use into other populations. And the interaction between venetoclax and its use as an induction agent and the subsequent place of transplant in the treatment of AML patients has been a major interest of ours. And that's really what I want to focus today's talk around. So there's really 4 primary questions that I want to examine as we walk through this. First question, looking at sort of a traditional older population, if you get Ven/Aza and you respond to it, who should get a transplant versus potentially continue on venetoclax and azacitidine? Number one. Number 2, can venetoclax and azacitidine replace induction therapy? And if it can, in whom should it replace induction therapy? Number 3, just sort of touch on briefly, how do we optimize the use of venetoclax in the initial therapy of an AML patient? Is Ven/Aza the only thing to do? Is it the right thing to do? And then number 4, can venetoclax be utilized as a post-transplant maintenance therapy? And if so, what's the best way to do that? Now, this talk is really going to be focused primarily on our Colorado data, and sort of deliberately as sort of the Colorado story on this. Certainly acknowledge a lot of these questions are debated, and they are very active topics of ongoing investigation across the board. So let's dive in here. So number 1, if you're a patient who's taking Ven/Aza and you're responding to it, who should get a transplant? Well, when we first started using this therapy, that was really a difficult question. And I've got a case here that I think helps to sort of lay the foundations. Got a 72-year-old with a history of coronary artery disease, some diabetes, normal karyotype IDH2, DNMT3A mutated AML, gets Ven/Aza and achieves a morphologic remission. Flow cytometry with high resolution flow cytometry that can detect measurable residual disease is negative, but we can still detect a very low level of IDH2 by digital droplet PCR, which we perform at our center and gives us a very high resolution look at the persistence of the IDH2 mutation. So after 2 cycles of Ven/Aza, we repeat the bone marrow biopsy, and the digital droplet PCR for IDH2 is now rising. Hematologic flow remains negative, and the patient's still in remission. So what should we do at this point? Should we continue Ven/Aza indefinitely? Should we continue Ven/Aza, do a bone marrow after each cycle? Should we stop Ven/Aza and monitor? I would add, should we switch the patient to enasidenib, an IDH2 inhibitor, which I didn't put on this list, or should we take the patient to transplant? So when we first started using Ven/Aza, we had no idea what was going to happen with our patients, and we were thrilled at the responses that we were seeing in them and the remission rates that we were seeing. And so naturally then the question would be, well, how long do you use it? Do these patients need a transplant? Is it possible that they're being cured by Ven/Aza? And, I think we were all a bit skeptical of the idea that we might be truly curing these patients, but we were seeing such good responses and good remissions in patients. I think we were also hopeful. And so then, what do we do? Again, the early population was typically an older and more comorbid population, so not necessarily a population that would be great candidates for transplant. But for those who were potential transplant candidates, what should we do? And as we think about advancing Ven/Aza into younger populations, how do we think about it? And so we didn't really know what to do, but we laid out some guidelines for how we might think about the issue. And this all sits in a publication that we had last year in bone marrow transplant. And the basic idea was, we thought, well, look, if you're a patient who has traditional poor risk features for AML, though that might not correlate with Ven/Aza responses, it's concerning to us. And if you're a patient who we can detect low-level measurable residual disease, even if you're in remission, and that disease is persisting or even rising, that's probably concerning and suggestive of the likelihood that the disease is going to come back. But if you had a great MRD negative response and you had more intermediate or favorable risk criteria, maybe those responses would be very durable, and maybe we don't need to transplant you if you're transplant eligible. And so we kind of tried to set up some guidelines for thinking about transplant recommendations for our patients who might be transplant eligible in the context of venetoclax and azacitidine. And so we went back and took a look at our data after we've been doing this for a while, and basically we had 119 patients who were newly diagnosed with AML and treated with Ven/Aza at our center. 61 of them were felt to not be appropriate to be considered for transplant at all based on age, social circumstances, early refractory disease, but 58 of them we thought would be reasonable for consideration of transplant. All of them had transplant consults. And we're a small enough group that we work closely enough that people aren't all getting lost in the shuffle, and we don't really see people for transplant consults if we don't think that they're potentially candidates for transplant. And so I would say that all 58 of these patients who had transplant consults were reasonable to consider for the possibility of transplant. A few of them were then subsequently not able to get on to transplant because their disease relapsed early or their social circumstances made it not feasible. But 52 of them we really considered to be people that could be transplanted. And of those patients that could be transplanted, we went on to transplant 21 of them, and 31 of them did not have transplants, both because of the fact that either they just didn't want to do it in spite of our recommendations, or we were trying to kind of stick to our guidelines and we were monitoring them according to the guidelines. They had more favorable features, and we hoped that maybe the Ven/Aza would do the trick for us. So, it's not a perfect study. Doing any kind of randomized study in this space would be very challenging, but I think it gives a fairly decent sense of what we might expect. And so these are the characteristics of the patient in this study. A little bit busy, a little bit of a tight slide, but I don't think we need to focus on the details of it beyond maybe just noting that the patients who went to transplant as compared to those who did not go to transplant were a higher risk group of patients. Considerably higher portion of them had measurable residual disease going into the transplant, or had morphologic leukemia-free states, so they weren't even in a good complete remission. So the group was a bit higher risk. The labeling that we put into this study, a little confusing. The SCT was the stem cell transplant population. This thing we made up, SCTETD, a little cumbersome, but that represented patients who we considered to be stem cell transplant eligible, but they deferred transplant. So if we take a look here then at the meat here and what we found, pretty striking outcomes here. Call your attention to the two black lines, solid line and hashed line, because that represents the patient population who went to stem cell transplant versus the population who we consider to be possibly eligible but did not go to transplant. Pretty striking difference there. A very high p-value, strongly supportive, I think, of the notion that among those patients who respond well to Ven/Aza, going to transplant is definitely the path that we should be strongly considering. Tried to look in these two other lines at the full population of all comers and that population of patients who we never thought would be eligible for transplant, but didn't relapse so quickly that they couldn't even have been considered, just to give a better even sense of comparator here. And I think, again, very clearly compelling data to suggest the benefit of transplant in this patient population. In these other slides, we tried to look at sort of some of the other issues that we might want to tease out to help refine things a bit more. These numbers are fairly small, so difficult to draw any major conclusions. But at least from the data set that we had going into transplant with a measurable residual disease, did not have a statistically significant negative impact on outcomes. I think that data is pretty preliminary, but I think it raises some intriguing questions about Ven/Aza we'll come back to. But then among the patients who deferred their transplant, we tried to look, if you had MRD or did not have MRD, if you were intermediate risk or adverse risk as compared to favorable risk, if you followed our guidelines or didn't follow our guidelines, could that help us to tease out populations where things might be different, and we could focus on those populations as being ones to think about a bit differently. We'll say that those patients who did not go to transplant but had favorable ELN risk AML definitely trended towards doing better than those patients who had adverse or intermediate risk ELN. So, I think in part this is provocative data to be explored further, but I also think it is fairly compelling data at helping to begin to address a very important question. And so my answer to this question for this patient, 72 years old, I think that otherwise reasonably healthy, if they were interested in moving forward with transplant, we would certainly be supportive of the notion of transplant. I will say too about that paper, of course, all of the patients that were transplant eligible, at least on paper, there were certainly some who were a little bit more questionable, who we might have tried to steer a little away from the transplant. And so it's not an apples to apples comparison. It's not a randomized comparison, but I think the overwhelming evidence of the improved relapse-free survival is quite clear. All right, so that's question one. Next question I want to look at, can Ven/Aza replace induction? And if so, in whom? This question, I think, is tied closely to the transplant question, but is also a very important question for the field in general. And so we've got a 27-year-old with no past medical history who presents with a complex karyotype P53 mutated AML. Rare combination, but something that we occasionally see. So what's the next best step? 7+3, Ven/Aza, gemtuzumab, and 7+3, or gemtuzumab, idarubicin, cytarabine, slag-ida, venetoclax. All right, so there's the question. So we have been sort of trying to explore this issue for quite some time now. I think I misspelled refining here. But in 2021, we published a paper that was intended to help to examine and begin to explore the question of who should get venetoclax azacitidine versus who should get induction chemotherapy up front. And so we basically looked at all of our patients who got Ven/Aza and all of our patients who'd gotten induction over the years, and sort of took a look at the data. So the main primary figure from the paper is this figure 1 here. And just to walk it through a little bit, figure A and B are the left side here is overall survival. The right side is progression-free survival. A and B represent all of our patients. And what they show is that among all comers, all of our newly diagnosed AML patients, the patients who got induction, that's blue, as compared to red, they clearly did better over the long term. However, that's not an appropriate comparison, because the patients who got induction were, generally speaking, young, fit patients, patients who clearly moved on to transplant if appropriate, patients who had sort of known curative consolidation strategy where appropriate. So what we did in figures C and D is we did what we call a propensity matching. And we basically tried to compare patients who had comparable characteristics in this pool. So it wasn't just all comers. And when we did the propensity matching, the curves flip, and those patients getting Ven/Aza as compared to those patients getting induced just shy of statistical significance for benefit in the overall survival for those patients who had Ven/Aza as compared to induction. So when you do an apples to apples comparison, or at least a closer to apples comparison, the outcomes associated with Ven/Aza appear to be comparable in large measure to induction chemotherapy patients. So there, the AML field has, I think, was quite reluctant to begin to contemplate accepting this, but I think they are increasingly doing so, and there are now ongoing randomized trials comparing Ven/Aza to induction chemotherapy to bring disease control for younger and more fit patients. Now, we also did try to identify features that might be associated with a higher likelihood of response to Ven/Aza versus intensive chemotherapy. I would say that this data is quite preliminary, and I'm not sure that I would hang my hat on it too strongly, but I would say that those patients with more adverse risk features, potentially those with RUNX1 mutations, those who are a little bit older, seem to trend towards benefit from Ven/Aza, whereas intermediate risk patients, particularly younger, fitter intermediate risk patients, and then this M5 thing that we've talked about for a long time, patients with M5 by FAB classification AML don't seem to respond to Ven/Aza as well. So that might be a group that might be more appropriate for induction chemotherapy. But I think we continue to try to push the envelope of this question. So now if we consider it in the context of stem cell transplant, we recently published a paper where we looked at our experience of those patients who had venetoclax and azacitidine and then went on to transplant versus those patients who had induction chemotherapy and then went on to transplant. And the characteristics of the groups here, the induction chemotherapy group, I think somewhat expectedly, is a younger group. This is our induction chemotherapy patient population for years, 140 of them that we looked at, versus 29 patients who got Ven/Aza. And I would note also that the Ven/Aza patient population, as compared to the induction chemotherapy population, was a little bit more likely to not have complete disease control at the time of transplant, had more reduced intensity conditioning regimens, again, a function of an older patient population. And then an important point that I would not ignore here is that a larger portion of those patients who got transplant after Ven/Aza also went on to have maintenance therapy, primarily with venetoclax. We'll come back to that issue, post-transplant maintenance therapy, but that's an important difference between these two populations also. So what happens if we look at the outcomes here? Well, all-comer outcomes, again, the numbers are relatively small, but the outcomes really seem to be quite comparable, and perhaps there begins to be a trend toward a better outcome with Ven/Aza. Again, more patients and more time needed, but certainly no striking finding in favor of induction followed by transplant. If we tease it out a little bit more, we wanted to look at an older patient population versus the younger patient population. It's an even smaller population of patients that are younger than 65 who have gotten Ven/Aza with us, but we do have some patients who do fit that bill. I think our primary interest was in older folks. If you got chemo versus Ven/Aza, would the Ven/Aza group clearly be doing better? Again, the 65 plus that got chemo induction is a pretty self-selected group. That's going to be a very fit group that that I think is not representative of your typical older AML patient. And in fact, there is definitely a trend toward an improvement in the older patients with Ven/Aza as compared to chemo induction. Again, numbers fairly small, but I think supportive of the notion that we would believe to likely be true, that that a fit older person getting Ven/Aza and going on to a transplant likely to do better, I think, than a chemo induction patient that then goes on to transplant. When we looked at the younger population, less of a trend, and I think that is probably not terribly unexpected, in that I think the younger population more likely to be able to tolerate the chemo induction, but certainly not a significant improvement as compared to the Ven/Aza population. So again, interesting data, we think provocative, and we hope will help to stimulate moving the field a little bit on the issue. When we talk about the transplant outcomes in these two populations, quite comparable. Big things we look at with transplant: what's the incidence of relapse? Comparable in both patient populations. The incidence of transplant-related mortality, dying from some toxicity related to the transplant, also comparable in both populations. And graft versus host disease issues, comparable in both populations. So Ven/Aza or induction, they don't seem to have profound impacts on outcomes of the transplant, at least in this data set, given its limitations. So for case 2, So we have, our young patient with complex karyotype P53 mutated AML. And I think that we would make the perhaps controversial case at the University of Colorado that we would likely start therapy with venetoclax and azacitidine for this patient if they were amenable to it. Now, I will say we're not just doing this willy-nilly. We have an investigator-initiated trial for younger fit patients who have AML, looking at ven-aza as the induction strategy. Interestingly, as a marker of the times, and we like to think the agenda that we've kind of been trying to push, when we first opened this trial, the FDA would only allow us to offer this to patients who had ELN unfavorable risk AML. So you had to be a very high risk AML for us to consider allowing you to take ven-aza as induction as compared to 7+3. But again, as a marker of the times and the data that's accumulating, just in the last month or two, the FDA has come back to us and they're now allowing us to include in this trial patients who have intermediate risk AML. So we are now allowed to take a younger fit intermediate risk patient and offer them this clinical trial. And we are hopeful that this will continue to sort of be the trend, because induction chemotherapy is rough. We don't love it if we can avoid it. Okay, the third question: how can venetoclax be optimized in the initial therapy of an AML patient? Well, again, we have been big advocates for the use of ven-aza as the initial therapy. And by the way, we also now have, in the relapsed refractory setting, an investigator-initiated trial allowing us to use oral azacitidine in combination with venetoclax. So we're on the cut for that patient population. They can come in and start on 2 pills. That's it. And prompt discharge and see change in the way we deal with AML. And very, very shortly, we hope we'll be able to be offering this as the upfront initial therapy. And so again, that's sort of the day we all dream of. You come in and you start popping 2 pills for your AML and get out of the hospital right away. Big deal. So we like that and we're excited about it. But of course, the way the world works and the way we do things historically, others are going to explore, well, let's add ven to traditional induction regimens. And the MD Anderson group has published on FLAG-IDA with venetoclax added, and their response rates do look encouraging. That's these top slides. Another paper, and I actually forget the group and the precise details, but it's another version of a ven plus induction-based therapy reporting kind of encouraging early outcomes. So yes, I think ven incorporated into induction is naturally something that's going to be explored. I think it's going to take time to sort all of that out. But we are also, interested in alternative ways that we might bring ven-aza into the mix, or the implications of ven-aza around this question. And Christine McMahon, who I'm not sure if she's on today, she's on maternity leave, and Kellen Gill, one of our residents, put together what's going to be a poster at ASH on our experience with the question of, okay, fine, if we want to do ven-aza and we want to start with ven-aza, but the ven-aza doesn't work, can we then go on to induce the patient? And if we do go on to induce the patient, what do the results of that look like? So, basically, is it safe to try ven-aza? And if it doesn't work, fine, then we'll bite the bullet and do induction. And the data set we have here is fairly small, but we do have 19 patients in whom we have had this experience. And the response rates for those patients, I would say, have been probably what we expected in this group of patients. They are naturally a very difficult group of patients. They tend to be the highest risk AML patients who aren't responding to ven-aza upfront anyway. But, we are getting response rates on the order of 50% in this patient population. About half of them we've been able to bridge to transplant, and those who have been bridged to transplant are by and large doing very well. So I think that the notion of ven-aza and salvaging with induction is a very reasonable one to consider, and we will continue to gather data on that question for sure. An alternative scenario that we run into, and we haven't gathered our data around robustly yet, but we are doing for sure, is the question of if you fail induction and then get put onto Ven/Aza, what do our outcomes look like in that group? Because I think we're very quick, if you fail induction, to go to Ven/Aza rather than keep hammering patients with multiple rounds of induction. And a corollary to that detail also is the question of, say you do go into remission with induction, but you do remain measurable residual disease, MRD positive. Can we use Ven/Aza to mop up the MRD in that situation? And if we do, what are the implications for the long-term survival of the patient if they go on to transplant? I would say we've only done that a couple of times and don't have a great sense of the outcomes data yet, but an important question that I think we would like to continue to examine. All right, moving on to our final question. Can venetoclax be used as a post-transplant maintenance therapy? And if it can be, how do we do that best? I'd also like to take a few minutes to digress a little on this topic and talk about the general issue of post-transplant maintenance therapy, because it is a bit of a challenging issue. So the case we'll examine here is a 67-year-old who has a history of complex karyotype, DNMT, got that goofed up too, DNMT3A mutation, IDH1 AML, who goes into an MRD negative remission with venetoclax and azacitidine. And at the time of transplant is MRD positive by FISH and cytogenetics for monosomy 7 and by digital droplet for IDH1. What maintenance therapy would be appropriate to use for this patient in the aftermath of a transplant, or would a maintenance therapy be appropriate? And I've listed a bunch of drugs here that one might consider in this situation. I didn't actually put ivosidenib in there, which is an IDH1 inhibitor and would probably be appropriate to consider in these circumstances. But I think a variety of possible options that we could consider thinking about. So I want to just, again, frame the issue of relapse post-transplant. On a statistical basis, the most common reason that a stem cell transplant fails is that the patient relapses in spite of the transplant. The likelihood of that is dependent on a variety of factors that we'll talk about, but could range from anywhere from 10 to, I think, even 60%, or possibly even a little higher in a patient who we might reasonably consider for a transplant. Relapses, if they're going to happen, will typically occur within the first year or two after the transplant. And as we think about things that we can do to potentially try to mitigate the risk of post-transplant relapse, I think there are kind of three major strategies out there that are considered. Number one, we can try and risk stratify patients for their relapse risk pre and post-transplant and use that to help us in thinking about what we might want to do. Number two, we can think about conditioning regimens and optimization of conditioning regimens, as well as donor source considerations to try to figure out best strategies to reduce the risk of relapse occurring after transplant. And then finally, we can think about post-transplant maintenance therapies, adjunctive interventions that we could have after the transplant to help try to reduce the chance of the disease coming back. And as we think about maintenance therapies, I think we can think about them as being prophylactic versus preemptive. Prophylactic would mean to me we're giving this therapy to the patients, all patients, regardless of whether they've shown any signs of relapse or not. Preemptive, which I think one could really argue is actually treating a relapse, would generally be referred to as giving some sort of intervention if there were low-level detectable measurable residual disease after the transplant, or some other risk stratification for a very, very high risk for relapse based on data that you gather after the transplant. I think those are the main strategies that we can be thinking about in terms of how we might reduce post-transplant relapse risk. So on the question of predicting relapse, I think the two most important prognostic features that we think about when we think about what is the likelihood that a patient's going to relapse after the transplant are, number one, is there detectable disease at the time of the transplant? That is measurable residual disease, low-level detectable disease by some assay that allows us to see small amounts of disease at a higher degree of resolution than just looking under the microscope. And number two, what are the genetic and chromosomal features associated with the patient's underlying leukemia? So with respect to the question of measurable residual disease, I think there is a growing body of data really across the board in all cancer therapies that suggests that the persistent detection of measurable residual disease at the time, basically at any time is not great, but in the context specifically of AML and allogeneic transplant, measurable residual disease detectable at the time of transplant is a negative prognostic risk factor that heightens the risk of relapse after transplant. And I've put in here a couple of different papers just referencing this concept. Patients without measurable residual disease clearly doing better than patients with measurable residual disease in both papers, higher risk of relapse if you do have measurable residual disease. However, I do like to raise some, again, perhaps provocative questions about this issue, and also point out some of the things that we all need to get further clarified about this issue. What exactly is measurable residual disease has not been clearly and standardly defined. We have a variety of different tools. We have flow cytometry, we have cytogenetics, we have FISH, we have different modalities of molecular testing to look for individual genes, next-gen sequencing, digital droplet PCR, et cetera. All these different ways that we can look for low-level disease. And I think that we are trying to become more standardized about which of these we might use and how we use them in a standardized fashion to better answer these questions. Because it is a little bit of a Wild West right now in terms of how people assess this and what tools they're using. And I think that in different circumstances, different tools may be more or less effective. And so I think that's a critical issue we all recognize is important. I think another important point about measurable residual disease is I think I am of the opinion that the timing at which it is measured is also potentially quite important, and that measurable residual disease that persists after multiple rounds of therapy is, to my mind, likely different than measurable residual disease very early in therapy. These are, again, questions that are all continuing to be explored. But I would raise the question about the additional possibility that in the context of venetoclax and azacitidine therapy, it is possible, at least with respect to if you're moving on to a transplant, that the implications of measurable residual disease prior to a transplant, if you've had ven-aza therapy, may be different than the implications of measurable residual disease if you've had multiple rounds of chemotherapy. So again, an area of interest and topic for future investigation. On the issue of the genetic and chromosomal profile and its implications for relapse, I think well recognized that certain abnormalities are going to be associated with higher risk of relapse after the transplant. These are just a couple of papers that demonstrate that also. I think we all feel that the combination of a TP53 mutation with complex karyotype is a very, very poor situation and one that we all dread and need to significantly improve upon. But basic ELN risk criteria, I think, have implications for risk of relapse, and there are certain other culprit abnormalities we know probably associated with more risk of relapse. But basically the bottom line here is that genetic and chromosomal profile important for the risk of relapse, and I think that's important in the context of maintenance therapies, as we'll come back to in just a minute. Other point that I would make about potential ways to mitigate relapse risk, conditioning regimen and donor source, I think, are both strategies that we can use to potentially strike balances in patients based on their relapse risk. I think there's a general truth felt to be true of stem cell transplant, that if you condition patients more intensively, that the risk of relapse will be lower. That typically comes also at the expense of a higher risk of toxicity and transplant-related mortality for the patient. And so that balancing act has to be struck for any given patient. And those patients that have higher risk features, I think for relapse, we might be more inclined to risk a higher risk of toxicity with the transplant to try to mitigate that risk of relapse. On the question of donor source, and the implications of donor source for potential outcomes post-transplant, there has long been a notion, and one that we are believers in our program for sure, that perhaps cord blood transplants, particularly if done in the context of a more intensive conditioning regimen, may be associated with a lower risk of relapse. Now, exactly why that's true, I think not entirely clear, if it even is true. But I think that some of it's felt to be related perhaps to the greater degree of mismatching that might be present in most cord blood transplants. But there is a significant body of papers that do suggest that relapse risk, particularly in high-risk populations, may be lower with cord blood than with other donor sources. And I reference here a New England Journal paper by my colleague up in Seattle, Filippo Milano, showing that those patients who had measurable residual disease going into transplant with their AML had significantly lower rates of relapse after cord blood transplant than with other donor source transplants, leading to better outcomes. So again, this is retrospective data, not a randomized trial, but it's data that's consistent with stuff that we've published and something that I'm inclined to kind of believe has some degree of truth associated with it. We are certainly always investigating novel conditioning regimens that might be tiered or risk stratified around risk of relapse, and hopefully also bring in more specific agents for a specific circumstance. But some people are throwing venetoclax into their conditioning regimens now and seeing if that has any impact on outcomes. So then the third thing that I think we can think about as a strategy for trying to reduce the risk of relapse after transplant is the introduction of some maintenance therapy. And again, we've got this sort of list of agents that I think that have been investigated and some agents that are under investigation. I would say the place where maintenance therapy has probably been most clearly established as potentially having a real benefit is in the setting of FLT3 ITD mutated AML. And there are a couple of randomized trials suggesting that sorafenib can improve relapse-free and overall survival if given as a maintenance therapy for a year or two after the transplant. Sorafenib is not terribly well tolerated. There was a randomized trial of midostaurin that did not show an advantage in that trial, kind of small, but there are ongoing trials with next generation FLT3 inhibitors. And I would say it's our standard practice at the university to give gilteritinib as our FLT3 inhibitor of choice in FLT3 ITD mutated patients as a post-transplant maintenance therapy. We find gilteritinib to be far better tolerated than sorafenib, and our anecdotal experience has been good. Long history of both hypomethylators and donor lymphocyte infusions as potential post-transplant maintenance strategies. Hypomethylators, typically azacitidine, possibly decitabine, given on some schedule post-transplant, often kind of 5 days out of a month for months after the transplant. Donor lymphocyte infusion would be the infusion of donor T cells, aliquoted by the number of donor T cells that you're giving, with the hopes to stimulate graft versus tumor effect. They've been used both preemptively and prophylactically. And then there are studies looking at hypomethylators plus donor lymphocyte infusions in various sort of permutations. I would say that the data on hypomethylators, DLI plus hypomethylators, all a bit mixed, none that I've seen that's terribly compelling about a benefit. There was a recent paper in Blood Advances looking at enasidenib as a post-transplant maintenance for IDH mutated patients, IDH2, I think, can't remember 1 or 2, but the appropriate one. Just a series of 19 patients published in Blood Advances and basically demonstrated that the drug could be administered post-transplant, but not a lot more that could be said, I don't think, about the paper. All kinds of other cellular therapies being considered now, graft manipulations, NK cell manipulations, et cetera, sort of morphing and merging into the general space of cell therapy and CAR T cells, and that's a whole other discussion, a whole other topic, but obviously an area of very active investigation. There have been some other agents that have been explored and published upon. Andrew Kent, one of our fellows, wrote up a hedgehog study that we wrote, a hedgehog inhibitor years ago, one of the first real post-transplant maintenance trials designed to hopefully target leukemic stem cells. Unfortunately, there was a fair bit of toxicity with it and no signs of significant efficacy. Panobinostat, lenalidomide have been invested, ivosidenib, IDH1 inhibitor under investigation, enasidenib in larger trials. So that there are there are efforts ongoing here, but venetoclax, quite an appealing agent for many reasons in our minds to consider also. So before we kind of finish off by looking at our venetoclax maintenance therapy data, I think a very important point to be made about the issue of post-transplant maintenance therapy. A few very important points to be made. First of all, you cannot cure the cured. We have for years, for decades, performed allogeneic stem cell transplants as the curative therapy for patients who do not have a reasonable, good alternative strategy for cure. And so a large portion of patients are cured, and we don't want to be subjecting them to additional therapy. So this question of risk stratifying patients and finding appropriate patients for maintenance therapy is quite an important one, I think. And we don't necessarily want to be treating patients who have extraordinarily low risks of relapse. Number two, when we think about a post-transplant therapy, both its tolerability and ease of administration are important issues. If you're giving any therapy prophylactically, you're going to be giving it to patients who don't necessarily need it. So it's got to be well tolerated. And I think importantly also, stem cell transplant patients have been through so much. They're often beaten up. They're often sick of everything they've been dealing with. They've been taking a ton of medication, and to ask more of them in the aftermath of a transplant is a pretty hard ask. And I think in the absence of clear evidence that there's real benefit, we have to be very cautious about asking more of patients who have been through so much. Important also to remember that when one has a stem cell transplant, their body is, and their immune systems are not the same as those of a native immune system in a patient being treated for AML who has not had a transplant. And any sort of therapy that you give in the aftermath of an allogeneic stem cell transplant may have a different toxicity profile or a more exacerbated toxicity profile than it has in the setting outside of a stem cell transplant. I think the biggest things that we generally worry about in terms of toxicities post-transplant that might be present would include, number one, any impact on graft function. Is it going to be, cause cytopenias, low blood cell counts? Could it kill the graft? That would be something we really don't want to see happen. Number two, is the therapy going to have any influence on graft versus host disease? Is it going to have some immunomodulatory impact on GVHD and trigger more graft versus host disease? Number three, is it going to impact immune reconstitution? Is it going to have an impact on the patient's immune system recovery, delay that, create more infectious risk? So those, I think, are big three questions we always want to be thinking about in the context of any post-transplant maintenance therapy. Of course, economic considerations are real issues also. These therapies can be quite costly. Again, if we're giving them prophylactically, that needs to be considered. So that's an important issue, always present in any decision making. And finally, duration of therapy. We gave this transplant for cure. How long do we give a maintenance therapy if we're going to give a maintenance therapy? So all challenges, none of which I have great answers to, but things that I think are important pearls to be aware of. So with all of that said, when venetoclax was approved for the treatment of AML, we initiated the off-label use of the therapy in post-transplant patients who we deemed to be at particularly high risk of relapse after the transplant. And the way that we defined that was being MRD positive going into the transplant, and we amended as we moved along to also include complex karyotype cytogenetics and P53 mutated patients. So we really tried to limit this intervention to patients who we thought had a very high risk of relapse. And what we did was, when patients engrafted, typically 40 to about 80 days post-transplant, and were otherwise recovering from their transplant, we started them on 100 milligrams of venetoclax daily, and we had a conservative up titration of it to 400 milligrams over the course of a month. Weekly, we increased by 100 milligrams just to make sure that patients were tolerating and we weren't seeing any significant issues. And we're in the process right now of finalizing a manuscript that we will be submitting shortly. We submitted something to ASH a few years ago, but we now have 53 patients with some degree of follow-up who have participated in our post-transplant venetoclax maintenance. Their characteristics are sort of listed here. I would just highlight the fact that the vast majority of them, again, as sort of would be expected by how we define high risk, were adverse ELN patients, almost all of whom had measurable residual disease at the time of transplant. And then again, the complex karyotype P53 is no great shakes for sure. I don't think anyone would argue that that's not a difficult population appropriate for intervention. So we have this plot here that Andrew has made, a really nice plot looking at the outcomes on an individual patient basis. And this sort of the period in red is sort of period on full dose venetoclax. The other colors represent dose reductions or the titration up of dosing. And then white are people who are kind of alive in follow-up and doing well. And so I think just eyeballing this, you can see pretty clearly that those patients who are out more than a year did this, the majority of them were able to stay on their venetoclax at appropriate dose for the majority of the duration of that year. And so that, I think, just gives a quick eyeball that looks like we can get away with this. If we think about, if we look at the toxicities here, always hard post-transplant to tease out what's what because there's so much going on, but not unexpectedly, a little bit of issue with cytopenias, a little bit of issue with GI toxicity, resulting in holds in a number of patients, at least temporary holds. But the majority of patients were able to stay on the therapy for the entire course, and spent most of their time on full dose. Looks like there's a question I'm going to be finishing up in just a sec, so we can go over that. And then if we look at just our outcomes data, the top two Kaplan-Meier curves here are overall survival. The top left is overall and relapse-free survival. Top right is the cumulative incidence of relapse and transplant-related mortality in these populations. So pretty good overall survival for such a high-risk population. 2-year survival over 50%, relapse rates at a year about 20-25%. We did sort of exploratorily compare the outcomes of this group to the hedgehog group that we had studied previously. And what we found, if we looked at all patients, trending but not significant improvements in the Venn patients in terms of overall survival, and a trending but not statistically significant reduced amount of relapse in terms of as compared to the hedgehog group among all patients. But interestingly, if we looked at the hedgehog versus venetoclax patients who were MRD positive by flow cytometry at the time of transplant, the Venn patients are looking strikingly better than the hedgehog patients. And that was a way to try and normalize a variety of different MRD strategies to one approach. I think importantly, again, raises the question of the implications of MRD pre-transplant in Venn patients. Also, I think raises questions about flow cytometry as a modality. And again, I would just note that between the hedgehog population and the Venn maintenance population, more of the Venn maintenance population had Ven-Aza induction, where more of the hedgehog population had traditional chemotherapy induction to try to get the disease under control. So again, variety of provocative things. Just to point it out, there is an ongoing Ven-Aza randomized phase 3 trial, all-comer AML patients randomized to Ven-Aza versus placebo as a maintenance therapy post-transplant. We are participating in the trial. It's a little tricky for us because we're also trying to do this Venn maintenance. And so we're kind of reserving our contribution for patients who we don't think are at super high relapse risk. But also this trial requires the azacitidine, which though oral hopefully soon, in its current formulation, IV is challenging to do because you got to come in again, you're post-transplant for months after the transplant. A lot of people don't really want to do that. So that's an important ongoing trial that I think will be very, very closely watched. So just to finish up case 3 for this particular patient, I think we would advocate for the use of venetoclax maintenance given the high-risk features of the disease at the time of transplant. And so just to finish up with a final slide here, some take-home points and questions that I think are important to continue to be examined. I think we are strong believers in the notion that Ven-Aza responders who are transplant eligible are likely to benefit from transplant in most circumstances. Ven-Aza induction followed by transplant really results in very good outcomes. Ven is an appealing agent to explore in post-transplant maintenance with a number of questions yet to be defined. And then some important questions, is MRD as prognostic following Ven/Aza induction if you're going to a transplant? And should Ven/Aza induction replace standard induction chemotherapy? And I think that's probably the biggest question for the field. So there we go. That is what I got to say, and I'm happy to take any questions if there are any.
Thank you, John, for that great talk. We do have a couple of questions here on the chat, so I'll try to go in order here. So I'll read them to you. One was already answered as you kind of went and talking through maintenance. So I'll skip to Anaga's question. So she said for case 2, which was a younger patient who presumably went on the IIT with Ven/Aza, how much of the data around P53 potentially conferring venetoclax resistance would change your decision in putting this patient on Ven/Aza?
Well, I think that we generally feel that P53 complex karyotype patients are horrible and we have nothing good for them, and it doesn't matter what we do. And so I think that we are still putting those patients on this trial for sure. I think our view of these patients is if they're transplant eligible, we're going to try to transplant them. They are a population in whom I think there is significant question about any benefit to be added by a transplant because of the extraordinarily high relapse rates. But I think our view has been, as is many's, that with nothing better, transplant makes sense. But I think we think about cord blood transplants, we think about intensifying conditioning regimens, and we give ven maintenance also. Does any of that matter? Not totally sure, but we're trying to at least do something that's a little bit more than just a typical transplant for that population. And on the upfront question, again, I think we don't have any particular view that induction is going to be better than Ven/Aza, and we think Ven/Aza is easier than induction. So we would probably give Ven/Aza to those patients. But we all know, and hopefully, Anaga, you will discover some way to deal with P53, or you, Maria. So anyway.
So we have a couple more questions. So one from Erica Swenson. So how do you use ABO typing during hematopoietic stem cell engraftment period and ABO incompatible transplants? Does your practice track ABO type, and do you use ABO type reversion, aka reverting back to host ABO type as a marker for possible relapse?
So ABO blood typing is an issue in transplant, a little bit kind of aside from I think a lot of the conversation around these issues, but and kind of a bit of a different topic. But the bottom line is ABO mismatching is something we can work around no matter what the ABO mismatch might be. There are what are called major mismatches and there are what are called minor mismatches, depending on which patient is which. All things being equal, we try to blood type match patients for sure. But if you have a major mismatch, and it takes me a minute to walk through this in my head always, but if you have a patient who is type O and a donor who is type A or type B, the patient will have inherent antibodies against A and B. So when you do that transplant, as the red blood cells start growing, you can have lysis because the red blood cells are being destroyed by the persistent antibody that ultimately goes away. And we'll also red blood cell deplete the product so you don't have an acute issue there. And that scenario can lead to sometimes delayed recovery of the red blood cells, but it tends to just work itself out. The antibodies go away, the donor cells take over. And so ABO mismatching has generally not been felt to be an ultimate sort of outcome predictor around transplant, although there's sort of papers on different sides of the issues. We absolutely can work around it. We don't really use it as a tool for following potential relapse because we have a lot more sophisticated tools to be able to do that, chimerism assays, and just assessments for disease itself.
Great, thank you. We do have one more question. How about adding another targeted agent to ven in the maintenance post-transplant maintenance strategy? So let's say like a FLT3 inhibitor or IDH inhibitor.
Yeah, totally reasonable and appropriate question. I think all these things are things that need to be worked out for sure. Obviously, the ongoing randomized trial is Ven/Aza because there is certainly more data. Single agent ven in the initial treatment of AML is not nearly as effective as Ven/Aza. So I think one could reasonably argue, why would you just do ven maintenance? But I think I've given you some reasons why we think it is a reasonable thing to be considering for sure. We didn't really get into mechanism of action things. But all of these targeted agents also are being explored, and then they will probably be explored in combination. I think we have to balance all of these issues. I will say it is our practice at our institution also, and I didn't mention this, but if you do have a FLT3 ITD, that kind of trumps us in terms of our maintenance strategy, and we will give you gilteritinib as our maintenance strategy, not ven maintenance at this point. IDH inhibitors, I think we're having some debate about that question right now, because there is at least now a little paper on ivosidenib.
Right. I think Jenny had raised her hand before, but I don't see it anymore. I don't know if she has a.
It might have been an error. So
Okay. Yeah. Otherwise, we are out of time. So I just want to be mindful of everyone's times. But I do really appreciate you, John, for giving that excellent presentation, and everyone for joining us today. And hopefully you can join us for other future presentations of the Symposia as well.
All right. Thanks, everybody.